Okay, well, welcome to the very amazing topic, latest on the news, buried under all the coronavirus uh, feeds, removable partial dentures. I know this is probably not the uh, hottest topic in dentistry either, but I'll try to show you guys what is happening nowadays with the latest developments in lab technology, how digital dentistry is changing what we do in every single aspect, even removable partial dentures. So for today's outline, I'd like to give you a quick review and discuss basic principles of removable partial dentures. I got something that'll feel a little bit like going back to school, but again, always reviewing these little principles help us understand in better detail and better depth what the advancements in dentistry, especially in removable partial dentures, can do for our clinical experience. We also are going to review a few different restorative materials and rest and undercut areas and what can we do in certain situations to help get that very nicely fitting removable partial dentures. Also, one of the topics I'd like to discuss today is we know that patients that often opt for removable partial dentures do so because of economic reasons, and knowing everything we need to know about fixed dentures, all in 4, all in 6, all in 8, whatever you want to do for full mouth rehabilitations on implants. Finding that step in between the patient that cannot afford all the implants that are necessary to rehabilitate a mouth and something that can significantly improve the function and comfort can make a huge impact on patients' quality of life outcomes. So starting now with a quick review of partial dentures, and there was a prosthodontist, one of my mentors when I started teaching at the School of Dentistry, that talked about a series of rules that he called the rainbow rules. That's why I have this rainbow in the background. Basically, what he was trying to portray is that if you can remember these rules or have them on top of your shelf when you're trying to plan a case, there is definitely hope that there will be a very good outcome out of that partial denture. So basically, try to always keep it simple. The simpler the removable partial denture is, then the easier it is to execute, to fabricate, and the patient will be able to wear it. And it's just a principle that applies to just about everything we do in dentistry. The less steps involved in trying to make something, the less likely we'll make a mistake along the way and complicate the outcome. Also, it's important to determine the cleanliness classification, decide whether the RPD will be tooth supported or tooth tissue supported. And this is something that should be done as soon as the patient is being diagnosed and we're coming up with a treatment plan. Because sometimes with the process of trying to figure out whether we need to extract teeth along the way to make a partial denture, the mechanics, the biomechanics of a tooth-supported partial denture will be very different from, for example, compared to a tooth tissue-supported partial denture. Only add components if need to, and you can justify using them. Basically, if you have an idea of putting a rest seat, a certain clasp, make sure you have a purpose for it. To be honest, in several situations where we have multiple dental sites that are staggered along the arch, it's not necessary to put one clasp for every abutment tooth that you have in that area. Basically, if you look at what's needed for retention, putting a clasp in one side of the arch at a time oftentimes gives you a very significant result as far as retention for removable partial denture. So if you can't justify putting 6 clasp on a partial denture, then there's no need to add 6 clasp for it. Use an eye-bar or wrought wire whenever you're doing a distal extension terminal abutment. Why? Because these 2 clasps are, by design, basically the best class to stress relieve a partial denture. Will have a lot more depressibility on the tissue area than it will on the teeth. It is estimated that tissue can depress more than 25 times compared to natural teeth when pressure is applied to it. So if you can imagine having a partial denture that is attached to a tooth, and then you have basically under occlusal forces a torquing fashion on that terminal abutment, those forces are gonna probably during the lifetime of the partial denture or the rest of the patient's life, going to be able to put a lot of non-axial forces on the tooth and can cause significant damage to the health and integrity of the tooth that is being retented by the remote partial denture. So I-bars and rot wires are the type of clasp that will allow you by design create a stress relief. Normally use a mesial occlusal rest on the distal extension terminal abutment, and I'll show you why. It's just gives you better mechanics, especially for the I-bar type of clasp. Whenever possible, cover the least amount of tooth structure and gingival tissue with the framework. That way, it's less likely that becomes a pocket for food. So the less you can actually cover the surface of the tooth, of the teeth and the gingiva, the less problems you're likely going to have with a partial denture along the way. Another of those rules is you want to stay about 3 millimeters from the gingival crest. Basically, when you're looking at your mandibular major connector, if you have that lingual bar that you want to put in, because the lingual bar is smaller compared to the lingual plate, but you have a really hard time between the floor of the mouth and that gingiva on the lingual aspect of your tooth to allow enough room for the thickness of that lingual bar. If you don't have at least 3 millimeters, it's likely going to become like a wedging area for food to get trapped in between the crest of the gingiva and the major connector. So it can likely cause more harm than benefit to have it that close together. So if you're going to have that issue, the best alternative to that is to basically go ahead and plate the entire lingual surface of that area. That way you don't have a superior border of your major connector being too close to the gingiva and causing a wedging mechanism for the food to get trapped in that area. Always cross the gingiva crest and maxillary midline at right angles. Basically, it's easier for autoclysis if it crosses the gingival crest in straight lines. And also in the maxillary midline, when you're trying to cross from one side to the other, if you have a major connector that's kind of skewed or doesn't cross the midline in a straight line, is more likely to cause phonetic issues for the patient because the tongue now has a different morphology, left side to the right side, and it's hard for patients to get used to that new morphology and adapt and overcome the phonetic complications that could arise from that. Use only embrasure clasp only when you have no edentulous space existing. Basically, I'll show you a slide along the way here that can shed some light as to why the double acres or the embrasure clasp can actually be very aggressive type of clasp to install, because the amount of space you actually have to make room for, usually in that embrasure space, the opposing dentition has a very tight fit with that embrasure. So making room for that clasp, you pay the price at the beginning or you pay it down the road, but there's a price to pay to use an embrasure clasp when you have an opposing arch that has teeth in it. I'll show you some slides that can help illustrate that. You also want to use a rest on either side of an edentulous area, because that helps provide better support and avoid sinking or settling of the partial denture framework into the patient's mouth. And always use proper undercut position and amount are critical for success. If you don't have enough undercut for your partial denture, what you have there is just a stabilizing arm, but the partial denture will likely come out just by a small sneeze. So making sure that you have the proper undercuts is paramount. So here's the reason why you always want to put a mesial rest seat versus a distal rest seat on a distal extension. So here in this slide, you can see that there is a red dot and a red circle. Basically, the red dot is illustrating where that rest seat would be. When you apply pressure on that distal extension, remember that tissue has 20 times more depressibility than the teeth, so it will likely rotate around in that fulcrum area. Having that distal extension basically makes that clasp that's attached to the entire framework rotate in a fashion that will likely engage on the tooth. It's going to rotate up and forward. And that's an area where if the height of contour of teeth is the normal way in that area, it will likely engage on the tooth and create a torquing force on the tooth. Whereas if, for example, we were to place the rest seat on the mesial area, then the fulcrum makes that clasp move in a very different direction. It's going to move downward and forward. And if that's the case, then it's very likely the clasp will disengage from the tooth when you are applying occlusal pressure on that distal extension. That's why distal abutments should never have an Akers clasp. If you can imagine Akers clasp attached to that tooth, especially on the distal, it's kind of a precision bridge attached to the tooth. Granted, have we seen that being done in dentistry? Patients come up to us and they already have a clasp on a distal extension that has an Akers clasp in there, and the tooth is doing fine. Yes, sometimes if the distal ridge area is not having any depressibility, we tend to see not much damage, but we can never guarantee that that's going to be the case. I've seen more cases of teeth actually being affected periodontally by having that Akers attached to the distal extension than when we, for example, use a stretch relieving clasp like an Akers and a wrought wire. I'm going to wait for the end of the lecture to answer any questions. I know that somebody raised their hand, but I'll wait until we finish the presentation. We have plenty of time to answer several questions. So thank you. Thank you for your patience there. So what hasn't changed in rural partial dentures? Well, we still have to do proper diagnosis and treatment planning in order to have a successful outcome. If we don't diagnose the teeth properly and come up with a sound treatment plan, the outcome is going to be a roll of the dice. And we definitely don't want the negative outcomes to be our norm or be something subjected to the fate or destiny of not thinking things thoroughly. So if we have control over that, doing proper diagnosis helps us identify issues that could be affecting the removal of partial dentures. It still requires, no matter how much of the digital aspect of it is embedded into this, it'll require multiple appointments because we have to still do a wax tray-in, metal framework tray-in, and and take impressions as well, whether we do them the conventional way or doing them digitally. And what doesn't change the fact that we can make the workflow a little bit easier, more streamlined, or less likely to have laboratory issues. At the end of the day, dentures are dentures. So remember, these plastic appliances that we're installing into the patient's mouth with a metal framework are not even close to how sophisticated Mother Nature did its job on the first time around when it designed teeth. This is basically an analog that falls very, very short to what teeth can do. We lose proprioception, we lose masticatory function, biting force is affected, and also quality of life and comfort is significantly affected by dentures in general. So that's one of the problems with partial dentures. There's still not significant breakthrough when it comes to that aspect. Another thing that's not changing is that either you or your lab technician need to be really good at surveying and identifying where the undercuts are. I have a love-hate relationship with my NA surveyor. I know that this is a instrument that has existed for way before I was even born, and it still remains in a lot of dental offices. And I know a lot of dental offices don't even have one, and they're relaying the steps of surveying your cast to your lab technician, at the end of the day, you have to remember that whoever is holding that NA surveyor needs to know what they're doing. So yes, I love that it can give me all the information I need to plan things properly and then design my partial dentures properly. But at the end of the day, whoever's holding that NA surveyor needs to know what they're doing. So if you haven't used an NA surveyor for ages, I suggest that every now and then, once this social distancing issue is out of the way, then pay a visit to your lab technician whenever you're doing a survey crown and have them show you and give you some tips on how they use it. You probably will remember a lot of the basics as far as where to find the undercuts and what routes you need to do. Maybe they have something even fancier than an A surveyor. And it's cool to see what toys they have. That's perfectly fine. But at the end of the day, this is an instrument that will tell you, if you're deciding which path of insertion you're going to have, how that partial denture is going to insert itself into the mouth, and where are the undercuts that will retain that partial denture. So surveying aspect still remains there. When you're moving forward with removable partial dentures, that's not an excuse to basically forget about taking good impressions. We have a thing that we say, that's kind of a bad joke that I repeat all the time at the School of Dentistry, wherever we're seeing patients. Even in my private practice, if I have to retake an impression, I take no shame in saying that, yes, as a prosthodontist, I do have to sometimes retake impressions. I know it's hard to believe, but yes, even prosthodontists can do that. And it's fine to admit it, that sometimes if an impression is not good, that if you ignore that aspect, basically you're starting off the whole workflow already affected by a flawed step. So taking good, nice, accurate casts where you're capturing all the landmarks is paramount to help you build up on a nice restoration. If you're starting off with casts that do not capture those landmarks and that do not capture the detail of the teeth, you're very likely going to be missing a lot of information that could be helpful in the planning process of your partial denture. So you need to have all the teeth included, and especially all the landing areas. If you have a distal extension, like the retromolar pad, the lingual sulcus, the buccal shelf, and so forth. And in the maxilla, you want to have the palate, the hamular notches, and the tuberosity, and the labial sulcus. If you have an accurate diagnostic cast, poor technique, and poor cast detail, or you basically over trim your cast or get rid entirely of a retromolar pad that could have been used for the support of your partial denture, then you're going to be missing a lot of information that will come in handy along the way. So an accurate diagnostic cast won't help you much. So yes, go ahead and take new impressions. That's perfectly fine. Casts need to be accurately mounted. Why? Well, one of the courses I teach is occlusion. This is something that I have a lot of emphasis on, because the articulator so far has been that instrument that allows us to analyze how the teeth relate to each other in all the different mandibular movements that we can do. If we do an excursive movement, or if we do a protrusive movement, we can see how the teeth are related to each other by the use of an articulated articulation device. Now, even with the digital world, I know that a lot of the impressions that are being taken, for example, with a Trios 3-shape scanner, just basically take segments of it. It wouldn't hurt if you take that segment and try to position it into at least something that is a virtual articulator, because that really helps you determine how the teeth will relate to each other. And especially in the planning phase, if you see an edentulous site, it doesn't mean that necessarily that space can now fit another tooth, because if that tooth has been missing for quite some time, you could end up having situations where the opposing dentition has subarupted or the occlusion has collapsed, and the space that you think you have available for a tooth is no longer there. I'll show you an example. here later of what happens when patients go about with partial denture releasing for too long without restoring them properly. When do you need to mount your cast, or why do you need to mount them? To evaluate occlusion and inner space, because that tells you where can you actually fit a removable partial denture. You know where are the minimum requirements of space and everything. So take a look at them with the articulator. One of the things that you cannot do intraorally, it doesn't matter how good of a camera you have or how much of a photographic memory you have, and just taking a look how the patient bites down, you can never look at the dentition when the teeth are related to each other from the throat view. So you can do that very well with an articulator, because basically the articulator doesn't have a throat, it just has space there. If you look in from the distal, from the back portion of your articulator seen forward, you'll be able to see how the teeth relate to each other, especially the areas that you think are going to be plating later with a lingual plate or cingulum recede or whatever. Areas that you're going to actually look into plate over, you can actually see them a lot easier that way than you will ever see them if you have just basically a mirror or an intraoral camera. You won't be able to see how, when the patient bites down, effectively how the teeth relate with each other. You can guess where the things are at, but unless you have diagnostic casts, you can really visualize them that well. When is it necessary? Mounting may not be necessary if the maxilla or the mandible that you're going to restore against is going to be an immediate or a conventional denture. Why? Because you have full control of where those teeth need to be. So, and how do you need to mount them? Well, basically, sometimes with removable partial dentures, yeah, you need an extra appointment. It doesn't happen all the time, but if you don't have adequate tripoding, you don't have good, stable contacts that tell you the actual relationship of the teeth, you have to make stabilized record bases and take another appointment just to relate the two casts together with those casts. Now, remember, this is an extra step just to mount the cast. It doesn't mean that you will then later use this mounting jig to mount your master cast, because there's two things that SBRs fit. One is the cast they were made out of, and the other one is the patient. That's it. They won't be able to fit any other cast. Why? Because every time we take a new impression, every time we take a new impression of the patient's mouth, doesn't matter if it's the same material, you will always have variation in how that tissue got captured. So these SBRs, this stabilizing record bases that you will have on the patient's mouth, can readapt to whatever the shape was, but on new casts, those are solid objects and they will not settle themselves to whatever the impression of whatever the shape of the previous cast was made out of. So they're not transferable, unfortunately. But what if you already made the switch and in your office you've incorporated intraoral scanners? You can definitely continue to use your intraoral scanner for removable partial dentures. It may not mean that you're completely done with impression materials though, and I'll explain a little bit why. It can do well for tooth-supported removable partial dentures. Why? Because intraoral scanners do an amazing job at capturing the shape of the teeth. The tissue that's captured with it is a mucostatic impression. It's basically a non-functional impression. In some instances, when we have a distal extension, we do want to take a functional impression, like a selective pressure impression, for example. Doesn't mean that you cannot fabricate the framework, but later on, you may actually have to have a cast that you then do an alter cast to. And incorporate that to your master cast, and then be able to process your acrylic base onto a selective pressure impression. Alternatively, you know that if you don't want to do an alter cast, there is good evidence that shows that you can overcome that by doing a reline. The reline, unfortunately, takes another appointment. It takes away the partial denture from the patient's mouth for another day. If you've got a quick turnaround with your lab, obviously. and it's an added cost. If you've already factored that into your fee, that's fine, but it will be more overhead for you. So AlterCast is a good way of avoiding having to do a reline or a rebase down the road if you need to. Oops, sorry. Your design should always be very well drawn on your cast. That is something that, this is a slide, as you can see, that I borrowed from my presentation when I go with the students, that we want to make sure that the design on the teeth, actually on the cast, is very, very easy to read. When you have easy to read designs on your cast, it's easier for your lab to interpret what is it that you want, much better than if you, for example, draw them on a paper. So what are the desired characteristics of diagnostic casts during treatment plan presentations? Casts need to be neat, clean, and incorporate all essential anatomical areas: labial and lingual sulcus, teeth, retromolar pad, hammer or notches, void and bubble free. That's something that with digital impressioning, that's all a lot easier to overcome. We know with the conventional impressioning techniques, when we go ahead and take an impression, we have to wait for whatever the setting time is of your algin or your BPS, remove it, and then that's when basically your heart stops and you take a look and make sure that you didn't capture a bubble in the wrong place. Now, if you're scanning intraorally and you basically know that's an area that looks kind of funky, didn't capture too well, the software really is very friendly in that respect. You can just basically erase a certain segment and restitch a new image that captures the shape that you missed or didn't capture properly for whatever the reason. So with digital impressioning, those are things that are definitely improving, not having as much problems as we used to have right now. You also need to be able to survey and design in a neat, legible way, and come up with a diagnostic wax-up whenever it's necessary. Why do we have to do, or why is it a good idea to do a diagnostic wax-up? Well, when we have edentulous spaces, if we do not account for the space that we have available, maybe sometimes we have too much space available, or maybe the patient had a lot of crowding, never told us that basically the teeth looked all crooked and before they got extracted. When you go ahead and try to set your teeth for your partial denture, now all of a sudden you don't have room for what you thought were going to be 4 teeth, and you only have room for 3. So what do? If you put a sleeve, you're going to have a different midline. With a diagnostic wax up, it's a very easy way of identifying the space that you will have available, and then are able to even communicate what is that you're going to be able to do for your patient before you even start cutting anything in the patient's mouth. So doing this diagnostic wax up will save everybody a lot of heartache down the road. I know it's a lot of work to do in the front end of it, but you'll be able to catch those situations a lot easier when you do diagnostic wax. So this is a situation that would have definitely benefited from doing a diagnostic wax. So why? Because if you see here, trying to set teeth in the space that we have here available, it's got pretty much, I don't think you can call this a curve of speed. It's probably the roller coaster of speed, where you have teeth that go up and down, up and down, up and down. It's like, how can you even fit a tooth in a edentulous space? Maybe somebody was looking at the cast and thought, well, I've got an edentulous space. I can definitely fit a denture tooth in place, and this is where I'm going to put my rest seats in there. But just looking at the occlusion and trying to identify areas where you can actually place your teeth is going to be very, very challenging along the way. So, so this is a good, bad example of what happens when you have diagnostic casts that are mounted, but you don't pay attention to where the occlusion is. So this is obviously a far more complicated case than just making a couple of metal frameworks and fitting teeth in place. Natural tooth modifications, plastic casts. This is something that we enforce at the School of Dentistry, and I do them in my private practice every single time. Why? It's not that I just want to see if I can do the modifications flawlessly every time. No, I want to practice, first of all, because it gives me an idea of how I'm going to modify that tooth before I actually do it on the patient. And then when you're having your discussion with your patient, you can actually show them, these are the dimples that I'll have to carve on your teeth before I go ahead and make you a partial denture. Why? Because for some people, just the idea of having to have a drill in their mouth is a deal breaker, you know, and you don't want to find this out to be a problem when you've already prepped one or two teeth, and now all of a sudden the patient's all upset because they have sharp areas in their mouth that they didn't have before. So making these modifications is a good way of getting informed consent from your patients, a good way of actually communicating with both yourself and your lab technician and your patient. What is it that you want to achieve? So having practice modifications on casts is primordial. Sometimes you have to do over contouring of the teeth, and I'll talk a little bit of what are the few things that you can do to overcome some situations where maybe you don't have enough undercut, or the shape of the tooth really doesn't conduct to a good retentive area for your clasp and whatnot. I wanted to also talk a little bit about reciprocating and bracing. Those are similar but not identical terms. Basically, bracing and reciprocating refer to the same thing. If you look at the reciprocating arm or the retentive clasp, basically the reciprocating arm is an arm that, as the partial denture is seating in place, you basically have a clasp that touches the tooth along the path of insertion, so that retentive arm that is going over the head of contour and into the undercut keeps the tooth from being tipped over. So because the patients are going to be inserting or removing this partial denture, hopefully several times a day, because they're removing any food debris and brushing the teeth every time after they've had a meal. If you don't have adequate reciprocation, the thought of this concept is that you're going to have issues where the retentive clasp will put lateral forces. Now, nobody has ever really come to a point where they've said this is something that has a significant clinical outcome. There's no randomized clinical trials that prove it one way or another. But what we know is that having good reciprocation does provide a very nice insertion for your partial denture. Now, when can you actually get a nice reciprocating arm? One arm that basically will be contacting the entire surface of the tooth in a straight line when you're inserting the partial denture. Probably the only time where you can do that consistently all the time is if you're making cervic crowns. Other than that, you cannot bank on having to carve all that much enamel to be able to have that nice flat surface of your tooth to be able to get true reciprocation. So when you don't have reciprocation, when you have basically a arm that antagonizes the retentive clasp but doesn't engage on the entire surface of the tooth during that path of insertion, that is called basically a bracing clasp. What the bracing clasp does is it stabilizes the tooth, the partial denture framework in the patient's mouth, and keeps the partial denture from being able to move around in those areas. So when the patient's masticating, those bracing arms keeps the partial denture stabilized in the patient's mouth. When you're sending these frameworks to your lab clinicians, remember, some are pretty good at knowing what is it that you over the years have come to like. But if you're learning new things, if you're now trying to incorporate new things, it doesn't hurt to give them always a very detailed lab prescription. We have this as a sample from the School of Dentistry, where we send basically all the information that we can. And this is just part of the information. We'll also like to send a 3D diagnostic design, basically a diagnostic cast, where we go ahead and draw the design on the cast, so that the labs know exactly how the framework should be fabricated. When we're sending the master cast to the lab, if you're not taking digital impressions, you're basically just still doing them with Alginet or VPS, you need to pour them properly. And the best material to use for the master cast is going to use die cast, basically type 3 stone. When properly poured and trimmed master cast is done, then basically you're going to have a good way of allowing the lab technician to fabricate a nicely fitting framework to your patient. Because you've done a lot of the legwork ahead of time and you've done the diagnosis ahead of time, you know what pathosurgeon you're going to use. Identify it on your cast, and it's not a bad idea to score your cast so that if they steam or something happens where they rub off the little marks that you have in there, if you have them scored, then they're easily identified down the road as well. So, and now that you know where the undercuts are, now that you've taken the time to identify where they are, mark them in red, and that's where your retentive tip should be at. And if you've got an opposing cast or opposing arch where you're going to be plating next to the occlusion, send them mounted. It's not a good idea to draw on your master cast. Why? Because let's say as you're trying to draw the design, you slip or you mark or you change your mind on how you want that design somewhere along the road after you're taking your master cast impression. Well, you can only take stone away, but you cannot just erase that line that you did. So if you're trying to erase it, you're scratching off the surface and you're taking away part of the accuracy of that master cast by trying to steam it off or brushing it off or scratching it off with a clear discoid. Remember, there's no easy way of removing that line that you made without actually altering the surface of your teeth. You want to do those on dry all you want on diagnostic cast. Why? Because you're not going to make your framework fit to your diagnostic cast. You're going to make them fit to your master cast. So it's never a good idea to draw your design on your master cast. Now let's talk a little bit of possible ways to enhance rest seats and undercuts, because I'm pretty sure that if you've been doing removable partial dentures in your private practice or in your daily practice, you'll find there are times where you don't have enough enamel or you don't have enough surface to make the proper undercut. So what do you do in those situations? Let's talk a little bit about the pros and cons of the different options you have. Well, again, the first thing you should always try is doing a little bit of enameloplasty. It's the most durable. It's no added cost because you're taking a handpiece that you would use no matter what on the patient. And it's relatively conservative because you're only taking away enamel that you need to make room for the metal framework or for that undercut, enhancement of the undercut. Cons are that sometimes the amount of undercut that you need or the amount of reduction you actually need to make will actually deplete the volume of enamel in that specific area, and you're going to expose some dentin. And if you have dentin exposure, you may produce sensitivity on the patient, or may require that now you do another more extensive restoration in that area just so that you cover the dentin in those areas. So enameloplasty is not the silver bullet. Should be your first thing you try because, again, it's very simple. But if you're running into situations where you're going to remove too much dentin, then or too much enamel and you're going to expose dentin, then let's look at other alternatives. The alternative is basically doing survey crowns. Survey crowns, if you have a nice lab tech that knows a lot about removable partial dentures, you're going to be able to create ideal contours that can easily be achieved on the hands of a skilled lab technician. In these situations, you can very easily get true reciprocation when you're making your frameworks because you will have control of how flat the surface is on the opposing surface to the class. So you'll be able to get very nice reciprocation. The problem is that it is less conservative. You're basically, the option is probably the least conservative. You're taking away all the enamel away. Now you're restoring the entire contour or coral structure of the tooth, or a big portion of it, with a restored material. And it always comes with added costs, both lab and chair time and your materials. So yeah, and patients, if oftentimes when they're opting for remote partial dentures, if they have money for multiple cervic crowns and a partial denture as well, what keeps them from being able to afford a few implants? So yeah, finding that if you have to do maybe 1 or 2 crowns, that can still make it worth it to the patient, money-wise. But if you have to do a ton of cervic crowns just so it can insert a removable partial denture, what keeps you from being able to just opt for an implant prosthesis? I've had situations where I've gotten really sophisticated with cervic crowns from removable partial dentures. Is basically when patients have contraindication for implants. So yeah, I mean, it's not your average patient, but there are patients that do need that type of restorative care. And then here comes the other alternative. This is basically do some restorative recontouring, add a little bit of composite, or add an additional non-precious overlay of a cingulum breast, and we'll show you an example of that. Problem with them is that there is some weak evidence, some evidence. I would say the only evidence that's available is like somewhat weak. It's not randomized clinical trials or systematic reviews by any means, but there are some retrospective studies, and numbers tend to be a little bit low, not necessarily huge numbers of people that are being evaluated over long periods of time. But it is what it is. It's what we have. So here's some of the clinical evidence that shed some light as to where we at. So sometimes patients cannot afford a cervic crown, and that's the reason why they're having a removable partial denture replace all of their missing teeth. Well, if you're in that situation and you have abutment teeth that you cannot grind too much without exposing dentin, then you can consider putting a little bit of composite and enhancing those areas. Problem with that is that you have a lot more, not a lot, but some more faster wear on the surfaces that are restored with composite or amalgam, for example, than to enamel. Now, if you look at the data and dissect the numbers, here's what it shows in this particular table. If you look at areas that have restorative material, 20% in a period of about 2 years have some type of wear. It's minimal, but it's some type of wear. Now, 20% out of 10 patients, this means that 2 may have a little bit of a looser class that I can later in 2 years go ahead and retighten the class. That's something that I think I've poorly served my patient of just go ahead and do a slight tooth modification with composite and enhance the undercut with composite, that I'm not going to be able to sleep at night. No, I know there'll probably be some wear, but in the contingency of having to do a cervic crown, maybe this is a better service for our patients. And yes, there will probably be faster wear, but if you have to redo the composite later, what is that going to cost for the patient compared to having to do a cervic crown? You can probably fit several composites over the lifetime of a patient compared to what you would get out of one cervic crown investment. Now, if you're going to use composite, here's what another article sheds light as to what type of material you should be using. This one compared dental composites to chrome and cobalt in different types of composite. Basically, their conclusion was that if you're going to use a composite, try to use one that has a very small particle size. So the smaller the particle size, the less likely it'll wear against chrome and cobalt. So you want those contours to last a very long time, use a composite that has a low particle size in it. And here's another alternative of what I was talking to you guys about. I can say I've never done any of these cases. I'm just reporting to you what's available in the literature. I have done the composite modifications. I've done enameloplasty. I've done cervic crowns, obviously, but I've never done this type of insert. But this particular study does swear that they tend to be very durable and they don't have any issues. And if you look at how they are made and they can be installed in the patient's mouth, they're easily remade or rebonded if they fall off. You basically use a bonding agent like Panavia to bond this to the enamel. You'll probably get a weak bonding against the metal, but you will definitely get very good bonding against the enamel surface. Making these single unrests are far better as far as having to do a very aggressive enameloplasty so that you have very good positive rest seats on your single unrest. So here's another article that shows that if you go ahead, instead of doing those inserts, you decide to bulk up the lingual surface of your tooth with composite, you can have a very successful outcome as long as when you're making that area that will positively support the metal framework has part enamel and part dentin, part enamel and part composite in it to be the supporting area of your rest. So yeah, this is a good evidence that shows that these type of rest seats can actually be very successful as an alternative to making that single rest seat or that chevron rest for your single rest. Now, what if you want to add the composite? Well, you know that to get that exquisite undercut, you can actually carve it real nicely on the surveyor, on your diagnostic cast, and measure it with your surveyor. But how do you transfer that nice wax that you did onto the patient's mouth? So this is a technique that I've used multiple times. I've got very good results. You can actually buy this VPS that comes in clear. There's multiple brands. I'm not sponsoring, I'm not being sponsored by this particular brand or anything like that. This is just the one that I have in my private practice. But you can use any clear VPS and copy that wax up that you did where you enhance the contour that you're going to have for composite. And basically in the patient's mouth, you go ahead and etch the surface. If you want to get even better retentive surface before you etch, you can actually sandblast the surface a little bit, then etch it. Gives you even more surface area to bond the composite onto it. Apply bonding agent, put some composite, and in order to make it flowable, you just warm it up in a water bath in a Ziploc bag so the water doesn't get to the composite, it stays dry. Put it in a water bath for a few minutes. Don't leave it more than 10 minutes in that water bath, because actually if you put too much temperature on the composite, it'll actually cure it. So you know how I know this? Well, it's because I left the composite for too long. So I always wait 5 to 10 minutes prior to me needing it, and that's when I actually dip the composite in the water. And that's when I go ahead and use it. If you leave it longer than that, it'll likely cure. So you'll get basically a big block of composite that doesn't extrude. But if you leave it there for 5 to 10 minutes and about 140 degrees, that'll make it nice and flowable. And you can fill up the areas on your clear matrix, insert it in the patient's mouth, and then cure through it now that you have a clear matrix to use it. Then once that is totally cured, you go ahead and remove any excess and verify you get the undercuts. Now, anytime that you're enhancing undercuts or making rest seats, it's a good idea. It's a good practice to do a quick analysis cast. It doesn't take too long. I know that people are just throwing their arms in the air because they have to take a neurologic impression. Well, teach your assistant to do that while you're doing an exam. Basically, go ahead and do the modifications and have your assistant take a quick impression and pour it with a quick blaster set. Then you go ahead and put that in your surveyor and hopefully if you still have one in your office, and then you can verify if you have the undercuts there. I promise you, if you take an alginate impression and put a quick plaster, it's not going to take you more than 10 minutes. And that's the time it takes for you to do a recare exam. So can you squeeze it in your busy practice? I think it's definitely worth it, because you can verify that all the modifications you've done are actually where they need to be. What do you see on the quick analysis as well? Are your guide plans correct? Are my occlusal plates and adjustments correct? Sometimes you have to maybe do a little bit of lameloplasty of the opposing tooth to see that you have enough restorative space. Are my rest seats correct? Do you have enough room for your rest seat? Sometimes just making the dimple for the rest seat is not enough. You have to look at the embrasure space and that marginal ridge. Once you have that cast and you mount it against your opposing cast, if the visualization of that reduction, it's impeded by the location of it. If you have a cast, you can rotate them in any single direction and actually see if you have enough reduction in those areas for your rest seats. Are your height of contour lines correct? Are my retentive features correct? Those are things that you can definitely identify with a quick analysis cast. Now, after you've done that, go ahead and finalize all the tooth modifications. And it is good practice to put a little bit of fluoride on the teeth. Why? Because we know that teeth that have been in contact with fluoride become, that basically the crystal of enamel becomes fluoropatite, is stronger and stronger to acid erosion than hydroxyapatite. So now that you've gone ahead and removed part of that outer layer of fluoropatite, then you've exposed hydroxyapatite, which continues to be strong, but it's not as protected as that fluoropatite that you have on the surface. So adding a little bit of fluoride, now that you've done the modifications, just take a little bit of gel and rub it against those areas. That's it. That's all you need to make a little bit of fluoropatite in those areas. And here's that slide I was promising you guys to illustrate that double embrasure rest seat. If you have to envision that the space between those two mounted teeth has to be 2 millimeters of space, and you don't think that 2 millimeters is too much, well, when was the last time you went ahead and made a 2 millimeter occlusal reduction for an all porcelain crown? It felt murderous, right? It still does. It doesn't matter. Every time you do it, every time I take a burr, I have to take 2 millimeters vertically from a tooth just so I can make room for my all porcelain restorations. I know I'm taking away a lot of enamel. Well, for double embrasure class, you need to make that much room. Why? Because otherwise, in those small areas, when you get the framework back, if you don't make enough room, your lab technician is going to give you the desired thickness, the minimum thickness they want, but you're going to put this in the patient's mouth every time patients bite down. They're going to have a lot of hyperocclusion in that area, and the next thing you do is go ahead and take a burr and grind it down in that area, making it weaker and weaker and weaker. And then 2 months down the road, after you've delivered that partial denture, if you were lucky enough to didn't fracture it at that time, the patient comes back to you and has a fracture class. Well, what do you do at that point? Well, if you make another partial denture that still has a weak link in that area, they're just going to break it another time down the road. So when do you decide to make that reduction if you have to do a double embrasure clasp on an area that is opposed with natural dentition? Well, you do the 2 millimeter reduction in that embrasure space at that point, or you do it later. You have to pay the price at some point. Otherwise, you keep on having failures, and that's not a good day in the practice. Survey crowns, what are the indications? Well, when teeth have large restorations on them, and you're going to now put a rest seat exactly where that tooth has that last bit of enamel that's holding it together, that's a good time to consider doing a cervic crown. Because you know, if you go ahead and do that rest seat and that last bit of enamel that's left on the tooth, you're going to probably weaken the tooth. It's going to fracture down the road. You don't want that tooth to fracture later if you can help it, especially if you can foresee it. Teeth that have very poor contours, no matter how much you enhance them with composite, you're just not going to be able to get the proper contours. for retentive class or guide planes or whatever, well, those are times where you can consider doing some cervic crowns as well, or teeth that, you know, just by standing there alone, you can, as you see them, you can almost hear the word timber, and then you know that tooth, before you consider it as an abutment, you should probably reinforce it with a all porcelain, sorry, a full coverage restoration. So what type of materials do you want to use for a cervic crown? Well, the go-to one, the most ideal as far as practicality, will always be the full gold crown. Why? Because if you have to then change later the contour and enhance the rest seat, you're not going to be worried about taking away too much of that veneered porcelain. It's easier to polish. It's very kind to the opposing dentition. The only problem with metal full gold crowns is that they're yellow. Let's face it. It has probably one of the best materials out there for the opposing dentition is full gold crown. Problem is, nobody likes gold teeth, at least not anymore. Maybe a rapper or something like that. But nowadays, it seems like less and less people like full gold teeth. So that's why we still have options like metal ceramic, PFM, where you have the receipt and that monolithic portion where the occlusal forces are going to be applied to it in metal. Again, because you only have a small area of veneering, you still have part of the tooth being a metal tooth and the other part being the pretty tooth. But you know, if you at least hide the aesthetic zone of that tooth with some aesthetic material like porcelain, then you can get away and get more patient acceptance. And then the other material you can use is a monolithic zirconia or porcelain infused zirconia. Problem with that is that zirconia is known to be not too amenable for adjustments. If you have to make occlusal adjustments, we know that zirconia tends to harbor microfractures that can weaken the material over the long term, and how this material is going to behave in the next 20, 30 years is yet to be determined. We have some knowledge that the material is weakened if you take a bird to it in vitro studies, but this material is not 20, 30, 40 years long or old at this point to know if there is any evidence in retrospective studies of how it will actually behave. So it's a relatively new material. Either way, whatever material you end up choosing, when you have a receipt, make sure you make enough room for it. Why? Because if you don't, remember that receipt's going to basically be a dimple on the coronal aspect. If you don't accommodate for that space in your preparation, then you're going to have a very weak area, a very small, thin area that could either fail by fracturing or be pierced if it wears a little bit, those areas. So on anterior teeth, if you're having single and rest seats, also you want to make sure that you accommodate for those modifications as well. And one thing you want to make sure that your cervic crowns have is, as you're making cervic crowns, is that lingual surface below the cingulum rest, or that chevron rest that you're going to have there, it does have parallelism with your path of insertion. That way your framework has a better adaptation there rather than being a pocket area, a reservoir for plaque or food debris down the road. When you are having cervic crowns, it's always a good idea to have the lab technicians just stop for a little bit, come back to your office, send the case back, and you taking the cast and taking a look at it in your surveyor. Or when if you cannot arrange for that, maybe you go to the lab technician's office and check it there with their surveyor and make sure that the undercuts are in the right place. One of the things that I wanted to illustrate is sometimes maybe they're focusing on getting you the undercut, but if you notice, these two crowns are likely going to need an embrasure class. What did the lab technician forgot to do on the image of the left side? Well, probably forgot to make the channel passage for that double acres. Now go ahead and gets that process, then it's more work to do, and you probably want your lab technician to do it. In the image on the right side, that new survey crown that you see right there does actually incorporate that channel for the double acres or that embrasure class to pass through. So checking things in their green state or the pre-baked state, it's a good idea because it allows us to visualize and verify that the undercuts and the restorative spaces are available for our future prosthesis. Now, sometimes we plan for the best and something bad happens. Well, you see the situation, looks like a partial denture was made and then a cervic crown was needed to be done. Now, historically, most people just go ahead and take an impression and actually have the patient surrender their partial denture so that the lab technician can make a crown that can fit to the partial denture. I'm going to show you an alternative to this. It does require a little bit of skills from your lab technician, but a little bit of practice to actually get very good at it. What you do instead of having the patient surrender the partial denture is you take your final impression, just like a normal crown would be, and then you insert your framework in the patient's mouth, make sure it's fully seated in the right position, and then that space that you have now created, go ahead and fill it up with exabyte. What that does is now captures the integral surface of that resting and that clasp. You can go ahead and trim that out, and then the lab technician can then, with a little bit of resin, copy the shape of that clasp and have an analog of the clasp, the guide planes, and the rest seats on the master cast, so you can fabricate a cervic crown that fits that. And then voila, you can get a crown that actually needs very little adjustment to be able to retrofit to class. Now, here's another set of tricks I wanted to show you guys as to how to tighten clasp. In this video here, these are very inexpensive little boomerangs. It's called Dent Supply. They have them, and they're not expensive. You can probably get one or two. If you had a very busy remote partial denture practice, you can get maybe 5 of them. It'll probably be sufficient. You can sterilize them forever. And basically have a couple of notches. These notches, one is bigger than the other. You find the one that best wraps around the tip of the clasp, and that's the one area that you actually need to adjust. You don't need to touch up any other area if your partial denture is done properly. Just basically to enhance that tip portion. And what you do is you bend it in and then bend it down. What that does is makes the clasp actually engage into the tooth, down and into where the undercut is. And it gives you the restoration back of your partial denture. Now I want to show you what has been done historically, conventionally, to make a partial denture. When you send a master cast to your lab technician, this is what they do. They go ahead and block out any undercuts and create room for the eye bars where they're going to touch the teeth, or block out any other areas that may have undercuts. And once that cast is fully blocked out, it gets duplicated and it gets poured into refractory cast. The refractory cast is basically now an analog of how that partial denture is going to be fitted onto and subjected to the lost wax technique. Now, lab technicians probably have a lot of these little patterns of wax that they can bend and move around and reshape around the refractory cast and make the shape of the, basically construct the framework however you ask them to do it, and the shape of wax, because wax is very easy to fabricate. And then they go ahead and sprue it, and lost wax basically go ahead and burn out all the wax and cast it with chrome and cobalt. And when it comes out, it needs to be desprued, finish it and polish it. You see there's a lot of steps along the way. And every step that the lab technician has to do to move forward the case is an opportunity to make a mistake. So that's why sometimes frameworks fit, sometimes frameworks don't fit. There's a lot of steps that you also took by the time you handed that cast to the patient, to the to the lab technician. So the more steps you have, the more likely you're going to have issues. Now, with digital technology, a lot of those steps are now a click of a button. And if you make a mistake, just unclick it. And then that's it. I'm going to show you here a video of nowadays how the digital technology is being changing the concept of the workflow of remote partial dentures. You can take any cast that you've been doing so far and just scan it. Lab technicians have all these scanners, or you can have an intraoral scanner and scan your own cast. That gives you an accurate model. And then after that, all that wax up, all that block out that I was showing you guys to do is basically a click of a button. And fast forward a little bit here, they show you that after the proper block out has been done, you go ahead and start fabricating the framework in place. And then from here, basically when this technology started to be used in dentistry, first thing they did is they printed a plastic pattern that then got sprued, and that plastic pattern then gets casted in chromium cobalt. Now, a lot of lab technicians, labs out there are using this technique because plastic printers are still very inexpensive. But we've gone even further in this technology. Instead of printing plastic pattern that now has to be invested and casted, and all the opportunity for introduction of error is there, you skip all those steps and go ahead and print it in metal. This came out about a couple of years ago. And when they first started coming out, the printed frameworks weren't that good. And nowadays, I can tell you from my own probably biased perspective, but from my clinical opinion, I've tried printed frameworks and they do beautifully. Basically, what this machine does is takes small particles of that metal and laser welds them, attaches them to the particles on the sides and what's below, and basically gets sunken in, and a new layer of powder gets attached, poured right on top of it, and a new printing laser goes over it, and that's how you get a pattern from it. So your frameworks end up looking like this. Cool thing about them is that if you later decide you want to do another modification, do a different shape of that clasp or engage a different part of the undercut, if your master cast is not changing, just a click of a button, you go ahead and make a new framework instead of having to pour a new refractory cast and make a new framework. It's very easy to print a new replica if you need to. So all those casting errors and flaws that were along the way, those are a thing of the past. It's pretty cool. Now, how can implants improve the situation? Well, implants, if we place them strategically, they can help support the removal of partial dentures in areas with high pressure to the tissue, like distal extensions. They can substitute anesthetic clasp or retention, because we have retention devices that can be disguised in the integral surface, or when properly executed, they can, with their minimal use, they can improve the comfort and aesthetics of removal partial dentures. I'll show you some examples here. Oop, that went too fast. Let me go back. All right. So what you see here is basically locator attachments being used. When you're planning these cases, please, 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 if you're going to place an implant, just to make it kind of be like a 2-implant overdenture, just assume that the patient at some point will likely lose the other teeth. So make it so that you will later be able to then convert that or upgrade it to something fixed or another removable prosthesis. Don't place it as to how it best serve the prosthesis at this point if you don't have a plan B down the road, because if the patient got to this point where they're now only having 2 teeth left, and you can place on 1 implant to try to enhance it and kind of serve as a stepping stone for you, just assume that at some point that patient is going to lose the remaining teeth. because chances are they will. And when that happens, then you want to not have to remove the implants or the work that you've done for them, so that you can continue to upgrade their mouth or overcome any shortcomings down the road. So locators can be placed in certain areas to help retain the prosthesis, kind of like a 2-implant overdenture on the Nile, as you saw it there. But whenever you're using locators, remember, locators, one of the problems is that they're kind of finicky and can only tolerate so much angulation. So if your path of insertion of your partial denture is not planned to the long axis of the locator, you're going to be burning through those nylons a lot quicker, or sometimes you cannot even use them if there's too much angulation. So take the time to look at the contour of your teeth. If you later, after you place the implants and you install the locators, find you maybe need to enhance the undercuts on the teeth, you can go ahead, by all means, do that. But look at the long axis of your implant, and then plan the path of insertion accordingly. Now, sometimes in some situations, if you're not looking at your restorative space carefully, you may run into situations where the restorative space that you see right here for your locators and your opposing dentition can be really, really significantly compromised. Now, that may mean that you may not have enough room for the aesthetic material that you need to install in that area, or maybe you have enough room, but the material is too thin, and every time the patient bites down, they keep on fracturing that veneer of plastic that you have over them. So always plan looking for your restorative space. In this situation, I would have not probably done what was done here. In my opinion, these abutment, these pontics that you see right here where the locators are likely going to be significantly challenged when occlusal forces are being applied to it, so they can easily fracture. I don't know what kept the patient in this particular situation from just basically getting conventional crowns, because it's one implant per tooth that's missing. But if you're going to use locators, you got to make sure you have enough thickness for them around them, and you want to, if you want to remember some numbers for that, it's 5 millimeters of diameter of space around it, and then you can put your denture tooth around it, and then you want to have 3 millimeters of height. That way you have enough room for the locator, the collar, and the housing that goes on top of it. That's the bare minimum. Here's one of my cases that I wanted to show you here. Patient came in to me, and I promise you, I'm showing you the x-rays of all the teeth that he's got. That's it. There's no molars. And he, at this point, he's been fine, but because he's been functioning with his front teeth, he noticed that one of the teeth broke off. He was fine without any posterior teeth. He's obviously functioning with only his front teeth. And medical history is pretty good, but obviously the restorative case got referred to me by a general dentist because all of a sudden things get really complicated, and patient was not ready for a complete denture. The dentist who referred him to me said, you might want to reinforce the idea that he may need a complete denture. He just didn't want to deal with the drama along with it. So I looked what was available there, and I saw if I could still come up with something for my patient. And here's what my treatment plan was. Basically, I went ahead, if you take a look at the situation here, yeah, there was a tooth that was completely unrestorable, but if you look at the bridge, and this patient had no idea this was going on, tooth number 8 was completely hopeless at this point. It had recurrent decay, very advanced, and pretty much just, if you listen closely, put your ear to the screen, you can almost hear that tooth say timber. It's like ready to fall off. So in those situations, it's best to cut your losses and say, well, we got 2 canines and an implant. What do we do in those situations? Well, in this particular case, what I went ahead and did, have my oral surgeon remove tooth number 10 and tooth number 8, and then I made 2 cervic crowns on those canines. And I established what my path of insertion would have been in order to create as much restorative space. Now that I'm going to incorporate a conus abutment. And for the mandible, I removed the pontic in the back. And the reason why I went ahead and did that is because now I can make a partial denture that at least doesn't have a clasp on the lateral. It has the support of the tooth and it's basically installed in there. And he already had a survey crown on tooth number 22. So part of the work was already done there. I'm glad the dentist who did that was thinking ahead. I think the patient had a history of having been fabricated or mandibular partial denture, just never wore it. I told him at this point, there's no way I'm going to make you an upper partial denture unless you're wearing a lower partial denture, because that will dissipate some of the forces when he bites down in the posterior area rather than confining him to just anterior occlusion. Because the next thing we're going to have is basically any of those canines fracturing off. And when that happens, I want to be ready for the next step. And that's what I would probably plan for this patient, is to basically convert him to a full arch of conus dentures if we place more implants. But I went ahead and replaced the maxillary anterior with a conus abutment. And that conus abutment is completely parallel to the path of insertion to those cervic crowns and the canines. And then on the mandible, I went ahead and made a partial denture that fits that. And the patient was wearing the process of me making those cervic crowns and the canines, a set of interim removal partial dentures. This is what the maxillary RPD looks like with the conus abutment installed in place. Has a couple of eye bars in the canines. I picked the eye bars because they tend to be more aesthetic. Patient had a lower lip line, so it was easy for me to mask it. And then the mandible, I went ahead and did the side that doesn't have that has an implant, doesn't have a clasp, and the other side does have a clasp for retention. Let's start a locator attachment there. That's how the internal photos look like in that area. And patient full smile, there's no metal. And it's hard to see which one is the denture teeth and which one is the... One other thing I did, and planning in this case ahead, is I looked at the actual mold that I was able to fit in the patient's anterior segment, and I had the lab technician match the shade of the of the denture teeth, because it's a lot easier for the lab technician to match a crown to a denture tooth. That is to find a denture tooth that match a pre-existing crown. So I knew that I was going to do a remote partial denture, so I actually sent those denture teeth that I knew were going to be able to fit in there, and have my lab technician match the the shape and appearance of those teeth. So that way, when the patient smiles, can virtually not see the skip between denture, plastic teeth, and porcelain teeth. So ideal workflow, and it's one of the last things I'm going to touch up on my course here today, is what you should be doing. Just a quick recap of everything we did. First, start with a comprehensive exam diagnosis and consult with any specialist whenever it's pertinent. If you have questions about the periodontal status or the pulpal status of any teeth, talk to your specialist and have them take a look at those teeth. Because if you need to have a root canal and then later have to put the tooth with a crown, you want to find that out before you make the partial denture, not after. It's a lot harder to make crowns that fit a partial denture than it is to make the partial denture fit existing crowns. So, treatment plan preparations, discuss alternatives with your patient. That way you can get nice, informed decisions from your patient and consent accordingly. Practice tooth mods and design casts and review them, discuss it with your patient. That way you'll know that your patient is fully aware of what they're getting themselves into. If cervic crowns are needed, all planned tooth mods should be done before final impression of cervic crowns. Why do you do that? Why is it important to do those tooth modifications? Well, when you're doing cervic crowns, remember, you're making a cervic crown and you're taking an impression. That's your free quick analysis cast. You're already taking an impression. And remember, you're going to make that crown favor the remaining teeth. So if you're going to try to maybe tilt the path of insertion so you favor a certain undercut on a tooth and try to be more conservative on your tooth, make those modifications and then find what that ideal path of insertion is, so that your cervic crown is made accordingly. If you make your cervic crown and then make your tooth modification, sometimes you may find later, then you have to then take another quick analysis cast, or maybe your cervic crown could have been done differently, which is a very sad part of what reality is, could have been done differently so that you could have favored other teeth that you're not going to necessarily restore with crowns. So yeah, always a good idea to do your tooth mods, because at this point you're going to take an impression anyways. You're going to pour that cast. Why not survey it and look at it as your quick analysis cast? Master cast for cervic crowns should be mounted, surveyed, and tap on it before fabrication of your cervic crown. Quality assurance and verification of lab work done before appointment, whether they send it to your office or you go pay the lab visit, however you want to do it. Just make sure you make some time for it. Then you want to do delivery of your cervic crowns, final mods, touch up if needed, and metal framework final impressions. Send the lab, mount it when needed with a completed and very detailed prescription. Metal framework try-in, alter cast if needed. Jaw relations, final tooth mold selection, wax try-in. Obtains patient's final approval. This is the last step in which the patient is involved in. That way they know, they kind of take a little bit of ownership in the process of making this partial denture. If you don't give them an opportunity to do that, then it's all on you if things don't go to plan. And then deliver and post-op evaluations. Always allow for 24-hour adjustments, 1 week, 2 weeks, 1 month. Why? Because when you first introduce a partial denture to the patient's mouth, you don't want that new shoe to all of a sudden start hurting the patient, or the new partial denture hurting the patient, and waiting 2 weeks of aggravated pain to be the first experience of their partial denture. You want to make adjustments right before they get too bad. So 24-hour adjustments are very, very important. And then after that, you give it a little bit more leash and cut them some more slack and give them another week, and then schedule them in 2 weeks and so forth. That way you're also seeing how the patient's taking care of their prosthesis. Are they cleaning them properly? Are they probably having issues that they're not even aware of, like irritation in certain areas, and patient's not, radar is not even picking up on sore spots. And then after you've done all that nice introduction of the patient into the prosthesis, you look at your maintenance phase. And normally, as patients have kind of a mild risk for caries, should have them come every 4 months. If you have, moderate risk every 4 months. If they have mild risk, then every 6 months. If they have very high risk of caries, you probably want to see them every 3 months or every 2 months. I have a patient that I see for cleanings every month, just because she wants us to clean them that often. She is in a nursing home and she knows that she doesn't do a good job, and she likes to visit us. So what's the problem having them come that frequent for us to do cleanings on them? So I know that a lot of you have probably fallen asleep by now, so this is time to wake up. I know I have that ability. My daughter reminds me of it. I was just caressing her a couple of nights ago, and this photo is from my 9-month-old baby. And I thought that she was just playing with my hand. She likes to do that. But also I feel like too much weight on my hand as I'm typing on my computer making this presentation. And then I realized that she had completely fallen asleep while I was holding her head. And that was the cutest moment for me. If you have questions, this is my email. I'm going to open the floor for questions in a little bit. So thank you so much for tuning in and zooming in. And it's a very difficult time for everybody. Thank you for doing what you're doing and staying home and staying safe. The fact that you guys are taking some time on very crazy times to continue to enhance your knowledge on removal partial denture says a lot about the type of clinician that you are. Deep respect for all of you that have tuned in today to listen to the latest topic of removable partial dentures. So let's see what we have here. Only 20 questions. That should be easy. All right. Most of the chat happening in the chat window. No. Let's see the open ones. How do I feel about flex partial dentures and recommendations for adjustments? Flex partial dentures should be considered whenever a metal framework is contraindicated. They do not have adequate positive rest seats. They just settle in. So they're like interim removal partial dentures. Now that's a different topic away from this prosthesis. I just find that the niches whenever for any flexible partial dentures is whenever you're needing to do an interim removable partial denture, or the patient has a true allergy to chromium and cobalt or acrylic, you can probably make them in nylon. They're not repairable. If you have to make a new clasp or adjust the clasps, make the whole thing again. You cannot bake anything to it. It's just best to make a brand new interim removable partial denture at that point. So that's my extent to it. There's newer materials that are coming out, and I've been using some of them in situations where a definitive is contraindicated, whether the patient is likely having very high risk of caries, where you consider doing an interim instead of a metal framework. Because if you're going to continue to lose teeth along the way, you anticipate that's going to happen the next few months, then why invest into making a very sophisticated metal framework? Just basically make an interim that you can add teeth as the patient continues to lose more teeth. Carrie Glasgow asked me, what are your thoughts on flexible partial dentures? I think I answered that one. Robert Springer here. In the office, I work we use a lot of Emax CEREC crowns. What materials do you recommend for survey crowns? PFM, full gold crown, and zirconia. Emax, it needs to have a certain amount of thickness. And when you are putting pressure in the areas where you have rest seats, the amount of thickness there is going to be significantly limited there. So if you want to use a material there, probably use a material that has proven qualities, and hence zirconia would probably be another option. I know CEREC has come out with zirconia. Even Glidewell is now pushing for I think the iTero system now allows for in-house zirconia crowns to be milled. All right. Here's another question. What was the class adjustment instrument I was recommending? You can use the 3-prong pliers, the 2-prong as well, but that's just a boomerang, little clasp boomerang that Dentsply has. If you call the rep and say, you know, what's that that little boomerang tool that you guys have that is to adjust Vitalium. Vitalium is their trademark for their alloy for chromium cobalt. They'll know which one you're talking about and sell you a few. No, they're not. I got a bunch for nothing because not many people know about them, and they have too many of them, I guess. So I mentioned it was okay to use an intraoral scanner to scan teeth for the impression for tooth supported RPD. What do you think about using a scanner for tooth tissue supported RPD when do wash impression at the same appointment as wax teeth trying before sending to the lab for final? The problem is how you incorporate the two together. So if you take a wash impression and you take a digital impression, eventually from that digital impression, you may need to make a cast, and how you combine the two together is the idea. Maybe there's someone smarter that's figuring out something more for that. But at this point, I think if you have an intraoral scanner, what you can do is have your framework fabricated from it, and then you do the segment that needs to have selective pressure impression, like a distal extension, and do an ultracast with it. Robert Springer here says, I noticed drawings on the scan cast in the video. Are they preliminary or final cast you scan? You can either take intraoral scans or take your final impressions, pour them the conventional way, and have those casts poured. Annie, from slide 45, what instruments do you use to bend clasp again? That's that Vitalium boomerang. The Vitalium boomerang. I'll see if I can find a catalog number and send it to Jo so she can send it out to you guys as well. Marie Johnson, can you go over the workflow when using an intraoral scanner for fabricating a metal framework for partial? Is it accurate on a tissue supported situation? Advantages and disadvantages in intraoral scanning versus impressions? Well, advantages are that if you have a bleb or miss an area that's important, like a distal guide plane or a cingulum resting, you can basically just stitch a new image to that. You don't have to take a full new scan, just basically the area that you have a defect on. So this is one of the main advantages of doing it digitally. Promise is the scanner does not take, only takes mucostatic impressions and basically captures the tissue relaxed with no influence of impression material on it. You only have air on top of that tissue. It's relaxed. If you want to capture under a functional impression, you may still need to make a tray adapted to your framework and make a functional impression from it. Sheldon, keeping aesthetics in mind, what is my experience using, oops, that went away. Cast flexi denture. The framework design is the same as the full cast denture, but using vinyl labial or buccal clasp. I have no problem with them. It's just that they don't have as much retention. They may need more undercuts in certain situations. And I know that some of the designs actually make those clasps very intimate with the gingival crest. I don't like those type of claspings because when you have a clasp that's fully seating on top of the crest, it tends to make irritation on the gingival crest over long periods of time, and that can be a problem over the years. But yeah, there's a lot of that being as an alternative. I know some people have even tried masking the chrome and cobalt with some paint, special paint, not Home Depot paint, but like special chrome and cobalt paint, or casting over it, or baking porcelain over it to mask it. Mixed results. It doesn't have, it still looks like a white piece of something on top of the tooth. So it's hard to mask it. I think it's like a sideways move in some situations there. Anonymous attendee, would I be comfortable using breed-in attachment on a distal lower canine with good bone support and single abutted, or for a bilateral distal extension RPD? Why or why not? Breed-in, I believe those are the tiny little ball sockets. Some of them are stress relieving specifically for distal extensions, and they tend to work well. Yes, that is just probably something I was not able to incorporate in my lecture because it can be very extensive. But yeah, it is. It's fine to use it in certain situations. If you have enough room, then to put your housing and the denture tooth. If you don't have enough room for that, then that could become a problem. I don't know if I'll get over all those. There's like 29 questions that keep on arising. I might miss a few, but I'll keep on answering as best I can. Heather, maybe I missed it, but why conus on the maxilla instead of locator? Yes, a very good question. So if I would have used a locator on the maxilla instead of the conus, the path of insertion was very buccal. So if I put a locator in there, I was going to have now a path of insertion that would have been more than 15 degrees from the plane of occlusion. It's going to go from like the front in, following the narrow portion of it, as would have also impinged on my aesthetic zone if I put my housing more buccal. Now, the conus allowed me to make that entire connection go a lot more palatable. And because I have control of that, I can make a custom of them at as angles I wanted. What I did in this particular case, I used the implant that was placed for an implant crown. It was never planned for a conus abutment. But then I created those crowns, surveyed, and made my path of insertion as parallel as possible, where I could tolerate angling that abutment, and I have a tolerance of about 30 degrees to make it more palatable, and then make my path of insertion favor the restorative space for my prosthesis. John Serrato, I can please send me a certificate. Yes, you will get a certificate. By the name of Mr. I believe is a boomerang from Dentsply. There you go. It's called Dentsply Boomerang. Stuart Rubin, material of choice for conventional secondary impression. If it's tooth supported, I like to use alginate whenever I can, just because it's inexpensive, and if you pour it and treat it properly, you can get as accurate impression as a VPS. Now, if you're disinfecting them for too long, it can suffer the consequences of imbibition or syneresis. Then in those situations, if you think that's going to affect your workflow, taking a VPS impression, it will increase your overhead because VPS is far more expensive than alginate. But all my alginates, I mix them with a vacuum spat. So they're very homogeneous mixes, and my assistants are ninjas when it comes to mixing up alginate in the vacuum spat. So I use alginate a lot of the times, even for my final impression. Now, if I'm not worried, if I'm not worried about having an undercut on a tooth or fracturing my teeth when I'm trying to remove it, I can make a custom tray and then take my impressions with light body around the teeth and monoface on the remaining portion of the tray. All right, precision or semi-precision on the last case versus the clasp. So the locator is considered a semi-precision attachment. The conus is considered a precision attachment. And basically, I incorporated that implant because I could. It allows the patient to have some vertical support, some fixed support on that implant when he bites down on the front teeth. So I'm getting actually a solid component on the interior versus, for example, if I were to use a locator. That's another reason why I use the conus versus the locator in the maxillary anterior. Patient tends to function a lot with the anterior teeth. Conus doesn't have a resiliency versus locator does. So if I have ponic teeth between the canines that where the center of it has resiliency, I'm going to have a lot of flexure, and those canines are going to flex every single direction there is. Whereas if I have an implant in the middle, at least that implant will provide a little bit of rigidity, keep the teeth from flexing when the patient bites down on the front teeth. So that's why I use the conus in that situation. And basically the implant was already there. So just try to make the best of it, of that particular situation. How would you feel about flex-based dentures like Valplast? Yeah, I think I already covered that earlier. How can you compare cast of patient's mouth and check for accuracy? Compare a cast of the patient's mouth and check for accuracy. When you get your framework back, that's the best you can do. I mean, obviously, if you look at your impression, if you see blebs or tears or things like that, you know that the framework's not going to fit. And that already looks inaccurate. The best you can is look for no blebs or no tears in the areas where your framework is back, and then you pray that your framework is going to fit. That's the best we can do. Sometimes I don't have a silver bullet there. Do you pour and scan or scan the impression? So for RPDs, you have to pour it because you cannot scan the impression and expect that the scanner will pick up all the intricacies inside the impression. The scanner is not that smart to go into where the teeth are on your impression and capture all those details. It can do it with completely dentureless impressions. It cannot do it with dentate impressions. So you have to pour it, and then that cast that you pour, you go ahead and scan that one. You always not plan for retentive class for implant retained RPDs. Whenever I can, yes. Why? Because who says, who has ever gone to your practice and said, you know, doctor, I come here because I want you to put a clasp on this tooth? No, they want you to fill in voids. They want the prosthesis that looks like teeth. They don't want the metal clasp around them. There's something that they basically accept to live with if they cannot have any other options. Kimberly, can I discuss types of RPDs, metal framework, acrylic, flex, and indications, contraindications for each? Yeah, so that's a very extensive topic. But as a general rule, my go-to is chrome and cobalt. It's inexpensive. It can be printed now, so it's very accurate. All other alternatives for me are good to fill in voids wherever an interim removable partial denture has to be used, or if you have a true allergy to the materials that are part of your metal framework removable partial dentures. Dan, how are you doing? Aside from being less aesthetic, is a T-bar clasp always an acceptable alternative to an I-bar clasp? Does it provide better retention? T-bar, yes, it can provide better retention. Problem with T-bar, if you're using it for a distal extension, the problem is that it may not disengage from the tooth as you would want it to do, so it could actually torque the tooth and cause some issues with it. So where that tip of your I-bar is what allows it to be disengaging when you have distal extension. So it may not be a great alternative for distal extensions based on the fact that it may engage on parts of the tooth that when you apply distal extension forces, it may not disengage from the tooth. Yusuf, can you please re-explain the difference between reciprocating versus bracing? Yes, reciprocation is basically whenever the clasp keeps the tooth from moving from the action of the retentive clasp going over the height of contour. That reciprocating arm cancels out the force that's being applied to the tooth by the clasp going over the height of contour. If that bracing arm is not touching the tooth on a linear pathway, what it's basically there's air. As it's fully seating, what it does is just braces it. It keeps the partial denture stabilized. It doesn't reciprocate it. It will only reciprocate it if it's touching the opposing surface of the retentive clasp on a linear fashion along the path of insertion. I hope this answers your question. Lauren Ashburn, are you comfortable sharing what lab you use for digital framework design? Yes, absolutely. I do a lot of my work with John Madden, which is a lab technician that is at the School of Dentistry. He, I believe, may accept work from outside clinics. I'd be happy to contact him and then have you guys have his information. I'll just share it with you guys later with another communication. But yeah, absolutely. Yusuf, thank you. Thank you. Is printed metal aluminum? No. Yes, that's a good question. That printer I was showing you, I didn't get a video clip of chrome and cobalt. being printed. But it's the same printer. Basically, you just change the metal particles. Instead of using aluminum, which was that example that was used in that printer, they use particles of chromium cobalt and use chromium cobalt instead. All right, inputs on clasping in the aesthetic zone. I like to use infrabulge class in the aesthetic zone just because it's easier to mask. Now, the patient has this high smile line, and they show the gingival aspect of the tooth. It doesn't matter if you put it in infrabulge clasp, like an I-bar, T-bar, or a suprabulge clasp, like Akers, Rottweiler. You are going to show that clasp. The patient shows the entire tooth. There's no way around it. Now, sometimes you can get really creative in making survey crowns that have all the guide planes parallel with each other. They have to be completely parallel with each other. If you have all the abutment teeth with parallel guide planes, it is proven that you can actually get retention just by the friction fit of that framework on those guide planes, and you can live without any clasping whatsoever. Yeah, I've done it a couple times. It works very nicely, but it's a very expensive partial denture because you have to do a survey crown per abutment tooth. So that can really increase the price of it. Amanda Springer, when retrofitting the crown to RPD, do you place the RPD over the prep tooth prior to injecting the blue bud? Yes, I do. Or should you express the impression material, then place it on the RPD? No, you seat the partial denture in place, and you take those the fine tip cannulas and inject the material inside, and make sure you really capture that inside portion of it. Now, when you take it off, you see a little void that it's going to get in the way. What you need to capture is basically the shape of the entanglement. That's very easy to capture. If you have a little void around the tooth, that's not going to be a problem. That'll likely fit nicely against your cast. But if you want to be type A like me, then just basically take a new mousse and inject it around it so you capture, you don't capture a bubble. Manleen, what are the prognosis if we use implant tooth as an abutment? The data shows so far they do very nicely. It's just that you have with abutments with implants a lot more flexibility to use locators or using conus abutments instead. So you can get away by using teeth that have crowns on them. To use other components on it. So yeah, you can use it. Imagine that it's a tooth, or hook on any other type of retentive device like a locator or conus. They will work fine. Just basically have to have sound mechanical principles for it. Kay Adams, how can dental hygienists support dentists and patients through beyond this process? Very good question. So what I actually have my hygienist do is basically every time a patient comes in and has had a partial denture done with me or a complete denture, have them remove it. And then they take a look at certain areas where they probably should be enhancing their oral hygiene or keeping the denture cleaner. Or if there's a certain area underneath the denture, you see a lot of food debris. Those are topics of conversation should be brought up during the chair time, obviously in a respectful manner. Nonetheless, you want to make sure the patient is aware that there is a deficiency. And if we're all on the same team to try to maintain their oral health, I mean, if they came to the office to have their teeth cleaned, they're obviously interested in having preserving what's there. Nobody comes to their office because they want to have their teeth cleaned because they just have too much money in their bank account. No, they do that as an investment for maintaining what they have in their mouth. So they're hiring you at that point to give them advice. Sometimes their mindsets gets in the way. If they think that you're being condescending or patronizing them, might get a negative reaction. So you have to be kind of elegant how you portray the situation, but if you notice something that needs attention, you might want to bring it up to the patient as, hey, you know, we're noticing that there are certain areas that are trapping significant amount of plaque, and we know how important it is for you to maintain your oral health. Can you give us an opportunity for us to give you some information on how you can probably improve your oral hygiene? Put the ball on the ring and have them understand that they're hiring you so you can give them advice on how they can maintain things in their mouth. So that's the strategy that I use with my dental hygienist. I want to make sure that they're not chastising the patient and make them feel bad about having a dirty denture. I want them to feel like the opportunity they're getting at this point to have their teeth cleaned, it's an opportunity to get an expert opinion on how they can do better when they're at home. So, yeah, I hope that answers your question. If you have any more topics, I'd be happy to expand on that. You always use metal partial for implant retained RPDs, or can you use something like acetal partial frameworks and allergic to metal? Yes, absolutely. I think I answered that earlier. Absolutely. Acetal is a great material. I think it's even better than Valplast. It's digitally milled. It's virtually indestructible. And whenever you want to do an interim removable partial denture or anything that is contraindicated, the acetal is pretty good. It's white. You cannot really pick too many colors for acetal. So it'll still look like something white around the tooth, but it's a little bit more accepted from patients. So whenever you cannot get the vertical support from the teeth that you want to engage from, acetal will be a good alternative. Did you still teach the ultracast procedure? Yes, I still teach it. I think it's a good alternative for mucostatic impressions. Sorry, not mucostatic, but selective pressure impression. There is some evidence that shows that you get, if you do a custom tray impression, that you get very similar results. As long as your framework continues to have similar adaptation to the cast than it does in the mouth, you can get away without doing an ultracast altogether. Or let's say you just do an alginate and you take on a mucostatic impression, but you later find that you have a little bit of rocking, you can overcome it by doing a reline. The problem with reline, it's an added cost, and it takes the denture away from the patient for one more day. So ultracast, you can just basically do it in between the process of making a prosthesis. And usually if you have a triad machine, you can turn around a tray on a distal extension within a few minutes. So the time you do your metal framework, you can still do your ultracast in the same appointment. Last flexible partial denture question, preference on Valplast Reflex or other. I prefer myself acetal if you're going to use an alternative all plastic material, just because it has a lot more durability. It's a newer material. God knows how it's going to behave long term, but the few that I've made have had very good success with. For a variety of logistical reasons or lack of quality lab results, what I do for adding crowns to an existing partial cut, existing class rest, and current partial denture prep crown, deliver zirconia, let cement, have potential compact. Next morning, take a conventional pickup impression, same day, partial repair, to lab, deliver, repair later that day. Would you consider this to be within the standard of care? It looks like a lot of steps, man. I hope you find a better lab. Maybe if you have, if you find somebody who you can work with that would cut some of those steps, maybe it would be a good opportunity. Hit me up. If you're within the United States, I can probably give you a couple of names of people that I can, or ask some questions from my colleagues. I know a lot of people around the U.S. and maybe find some answers for you, okay? Claudia McDaniel, let's see. Hi, how you doing? Nice to see you again. Nice to see you too. So case with implants, natural teeth, and partials, how do you balance the occlusion with occlusal scheme? Thank you. Well, whenever you have partial prosthesis against partial prosthesis, if you have denture against denture, if the denture tooth is going to be opposing another denture tooth, you do balance, basically balance occlusion. If you have a natural teeth against prosthetic teeth, you want to do group function whenever you can. If you have natural teeth against natural teeth, then if you already have canine guidance, you preserve the canine guidance. I know it's a little bit of a loaded question, but if I did not answer correctly, send me an email. I'll be happy to answer them. Tuan, thank you. Welcome back to Minnesota. Let's see, do all labs know how to make abutment crowns retrofitted into existing parsons without pickup and brushing using the lab, as you mentioned? If they don't, I'd be happy to give you the, there is a, if you look at my slides, there is a, that's an article that you can actually download and send it to your lab technician. They can read through it and attempt it. Now, you probably don't want to be the first one that does it. So if you're going to come back now to Minnesota and start getting yourself started into the dental business here, maybe call the labs that you're going to be working with and ask them if you already know how to do that. If they don't, send them the article ahead of time so they can practice and maybe come up with other suggestions. So yeah, I can give you the step-by-step if you don't find it online. We have copies of that in our office. So slides 37 through 40 for reference. You're welcome, Tuan. Hamad, I think the item you were talking about is called Vitalin Class Adjuster. Yep, that's the one. Thank you for that link there. Can I review the technique of pickup impressions to retrofit the existing RPD? I'd be happy to find that step-by-step in more detail and forward it to Joe so she can share it with all of you guys too. I think it's just too long of a question to answer in here. Jacob, are there benefits of utilizing bracing over instead of reciprocating for acres? Benefits over, and well, it's just more convenient and less aggressive of a preparation of the tooth. So, and reciprocating, well, you're less likely to cause a lateral movement of the tooth when you're inserting the crown. Now, is there any evidence that shows that patients that only have reciprocation, only have bracing and no reciprocation, lose their teeth more than the people that do have reciprocation? No, and I don't think we'll ever see randomized clinical trial that proves it one way or another. But the theory is that with reciprocation, you don't have lateral insertion or lateral movement of the tooth. It's got nicer fit of a framework, that's for sure. With limitations in tooth contours, would you recommend having the retention class on lingual and bracing class on the buccal? Would that be biomechanically sound? Let me read this question again. Limitations in tooth contour, would you recommend having the retention class on lingual and bracing class on the buccal? No problem doing the bracing class on the buccal. It's just that it's easier if the retentive portion is on the buccal because that's easier for patients to remove it. But there are times where your undercut is on the lingual and not on the buccal. So yeah, you can definitely use the lingual undercut instead of the buccal. I think this will be my last question. I've gone way over time here. Jessica, there's a wonderful question from Tuan Lee. Can you please answer this? Do all labs know how to make an abutment crown retrofitted? Yeah, I think I answered that one. And that's it. I tried my best.